Good morning, everyone. Thank you for joining us. I would like to invite Isobel Mackenzie, British Columbia's Senior Advocate, to the podium to make her announcement.
Thank you, and good morning. I am Isobel Mackenzie, BC's Seniors Advocate. And before I begin, I would like to take a moment to acknowledge that I stand here on the traditional territory of the Lekwungen-speaking people of the Esquimalt and Songhees First Nations. And I, like many, am grateful for the generosity they show in sharing their lands with us. Today I am releasing a report from our province-wide survey on the impact of visit restrictions on long-term care and assisted living. Never has one issue dominated the phone lines and inbox of my office to the extent that visit restrictions in long-term care and assisted living have. And as the Seniors Advocate, of all the reports that I have written, none have been as difficult as this. No person could read the letters and comments that came with this survey and not be deeply and profoundly touched by the obvious love and devotion that some family members have for each other, and the pain they feel from the separation current visit restrictions have imposed is palpable. These husbands, wives, sons, and daughters are, without a doubt, essential care partners for their loved ones. There are literally thousands of residents in this province who went from seeing their loved one almost daily to seeing no one for 4 months. And now, for the last 4 months, many of these visits are 30 minutes, once a week, often outside, sometimes between plexiglass, and usually with someone watching. I am absolutely committed to honoring the voices from this survey in a more fulsome way than this report can capture, and I will be issuing a compendium report in the near future that will honor the unique experiences of the more than 13,000 residents and family members who told me their story. However, I want to share one story today from a recent widower. Widow. I was even denied window visits as his room looked out on the courtyard. He celebrated his 75th birthday, his last, through a window. No cake, no balloons, no semblance of a celebration. And my 70th birthday, we couldn't even get together. We celebrated our 50th wedding anniversary outside, 6 feet away, through a wire fence. No touching. My husband did not know why I couldn't come in. He was way beyond understanding what was happening. Had I been able to hold his hand and tell him that I still loved him, and that I was not abandoning him, he might still be alive today. He simply chose to stop eating or drinking. I believe he lost all hope of ever seeing me again. And what is the purpose of living if we have no hope? Managing COVID-19 in long-term care is one of the most challenging issues in this pandemic. We imposed restrictions on visits because we care very deeply about protecting our seniors. We were staying apart to stay safe. We know the devastating effects if COVID spreads through a long-term care home, and we wanted to keep our vulnerable seniors who live there insulated from the ravages of this pernicious virus. The provincial health officer, Dr. Bonnie Henry, took swift and sweeping actions related to long-term care at the beginning of this pandemic. And in support, the government directed significant resources, quickly and without argument, to our long-term care sector. I continue to believe that these actions are the reason we have managed COVID-19 in long-term care with relative success here in BC. And to both the provincial health officer and the provincial government, you have my profound gratitude. When we initiated visit restrictions back in March, most of us, myself included, supported the measure. However, I did not foresee that 9 months later, we would be where we are today, with continued prolonged separation for some family members and only brief impersonal visits for many more. Through this survey, we found that the relief many family members and residents thought was coming with the easing of restrictions at the end of June has not materialized in a meaningful way for many, and the continued limit of one designated visitor has meant that many adult children have been separated from their parents for almost 9 months. As has been mentioned recently, this virus has now actually been with us for almost a year. And we still have as much in front of us as behind us before this pandemic is over. However, we have learned much about how this virus transmits, and we have built significant capacity in the healthcare system to manage this pandemic over the long haul. In BC, we have about 349 long-term care sites and 212 assisted living sites. And since the first outbreak in March of this year, 20% of our long-term care sites and 7%, of our assisted living sites have experienced an outbreak. And 97% of these have been contained to the Vancouver Coastal and Fraser Health regions. The majority of our outbreaks to date have been contained to a single individual, usually a staff member. And thankfully, 72% of our outbreaks to death have resulted in no deaths. And overall, around 1% of all residents and less than 1% of staff in long-term care assisted living have been infected. Over the past 9 months, we've seen a shift in the relationship between our outbreaks in long-term care, our hospitalization rates, and our daily new case count. I wonder if you could go to the slide, please. As this graph illustrates, at the peak of the first wave, we were experiencing more outbreaks relative to the average number of daily new cases than we are today. We were also experiencing a higher rate of hospitalization relative to our rolling 5-day average of new cases. This is important context, particularly given the number of new cases we've been experiencing in the past weeks, especially in this past week. The number of outbreaks that have been contained to a single staff person is also important context. Thank you for the slide. Together, these data tell us that our layers of both detection and protection can be effective in keeping COVID from entering and spreading in our long-term care settings. However, it's not absolute. We still see outbreaks, and some of those outbreaks are still spreading dramatically within the care home. We cannot get this risk to zero. However, the risk of death and injury in long-term care never was and never will be zero. During the same time frame that 151 residents passed away from COVID-19, over 4,500 residents passed away from a disease, illness, or condition other than COVID-19. In long-term care, the goal is not immortality. It is quality of life in our final years. Next slide, please. There are some warning signs that we're not meeting this goal. This chart shows the rate of use of antipsychotics, and it's increased 7% over the past 7 months during the pandemic while we've had visit restrictions. And as you can see from the steepness of the slope, this is a very significant increase as we look over the past 3 years and what kind of variation we generally find. We are also seeing emerging signs in our clinical assessment of increases in unexplained weight loss and a worsening of mood and symptoms of depression. These data help explain why over half of families reported their loved one had declined either physically, cognitively, emotionally, or in all 3 areas. Thank you for the slide. We announced this survey on August 26th, and in the following 5 weeks, over 15,000 people participated, and they provided over 13,000 valid responses. We heard from family members, from residents, members of the public. We heard from all areas of the province, from those in long-term care, those in assisted living, whether they lived in private, public, or not-for-profit owned and operated sites. These people cared enough to reach out, to spend a considerable amount of time completing this survey and telling us their story. And they told their story with accuracy, candor, reasonableness, respect, wisdom, and most importantly, love. Today, I am not reporting the totality of their story. I cannot do justice to that in the time available for this media conference. However, I can highlight some of the findings. Prior to the pandemic, over half of the respondents were visiting their loved one for more than an hour, several times a week, and in long-term care, 20% were visiting daily. When restrictions were first imposed in March, they allowed for broadly defined essential visits. However, the survey found these essential visits were not managed or communicated in a uniform way. Over half of family members reported that they were not advised of the possibility of essential visits. Not surprisingly, less than half of the respondents applied to be an essential visitor, and almost half of these applications were denied. Overall, 14% of people were an essential visitor. The survey also found that some of the alternatives to the in-person visits, such as phone calls and Zooms and Skype and FaceTime, were of limited value to those living in long-term care, where over 75% need help all of the time, or mostly all of the time, to use any of these communication devices. And they required precious staff time allocated to the task, and even then it was very problematic for many people to communicate through these mediums. Some residents did benefit from this and used it frequently, and those who lived in assisted living, not surprisingly, had more success with this technology than those living in long-term care. At the end of June, visit restrictions were relaxed, and we moved from essential visits only to every resident entitled to a designated visitor, and we called them social visits. However, we learned through the survey that 2 months later, visits are still heavily restricted. Currently, most visits are only once a week or less, and half the visits in long-term care are 30 minutes or less. Most visits are in common areas with staff observing the visit. Only 21% are in the resident's room. And it should be noted that 75% of long-term care residents and almost 100% of assisted living residents live in a private room. 30% of our visits are still outdoors only, and 18% have plexiglass between the resident and the loved one they're visiting. 3 out of 4 visitors cannot touch their loved one when they visit, whether they're an adult child or a spouse. As I mentioned, during the time of visit restrictions, over 45 residents have died from something other than COVID in long-term care, and about 10% of our survey respondents either had a loved one who is currently designated as palliative or their loved one had passed away during the visit restrictions, and we asked them some specific questions about their experience. Half of these people reported they were not allowed to spend as much time as they wanted with their loved one before they passed away. And over half reported that they were restricted to 1 visitor, or in the case of 10% of respondents, no visitors. 2/3 of family members reported their loved one passed away a week or less after they were designated palliative. So where do we go from here? How do we balance our responsibility to keep people safe during this pandemic with the need for those who are nearing the end of their life to spend what precious time they have left with the ones that they love? Family members have told us through this survey that they are absolutely on board with booking visits in advance, health question screening, getting their temperature checked, washing their hands, wearing a mask. But in exchange, they want to visit their loved ones in the privacy of their loved one's room. They want to be able to touch their loved one and they want to see the person that they used to visit basically daily more than 30 minutes once a week. The majority of family members and residents have also indicated the need to expand the potential visitors to more than one. For some residents, the number of visitors will remain at one. They only have one person who will come and visit them. And sadly, there are some residents who will continue to receive no visits. But there are other residents where some of the immediate family, adult children in particular, need to be able to see their mom or dad. It's been almost 9 months now for some of these family members. And without a change, it could become 9 months more. One of the interesting things we found in the survey is that residents are not as worried as we might think they are about contracting COVID. This may reflect to a large extent the recognition that comes for many long-term residents that they're nearing the end of their life and that it's quality of life that matters. It may reflect this question was asked more than 6 months after visit restrictions were implemented and family members and residents were seeing things in a larger context. Regardless of the reasons, we need to respect the voices of those most affected. My report makes 3 recommendations. First, all residents need the ability to designate an essential care partner. It is the resident or their family member who should decide this, not the care home. And this designated essential care partner needs to be able to visit their loved one more frequently and in the privacy of the resident's room if they live in a single room. Second, residents need to have a social visitor in addition to their essential care partner. The number of social visitors allowed should be sufficiently flexible to allow immediate family members to see their loved one. For example, if you have a spouse who is the essential care partner and there are 2 daughters, we need to allow for both daughters to see their dad. However, we also need to balance this with risk and safety, and it may require changing social visitors on a monthly rotation rather than a permanent expansion. Thirdly, we need a better way for residents and family members to have their voices heard. This was a gap that existed prior to COVID, but like many things, COVID has revealed why it is a gap we must close. I am recommending the Ministry of Health work with my office to establish a provincial association for resident and family councils. I realize that we are experiencing record numbers of new cases, most acutely in Fraser Health, and that we are experiencing a number of new outbreaks, particularly in Fraser Health. But we need to look at the total picture, and we need to remember what we know about this virus, and that we have many, many more months, if not years, of managing it ahead of us. Allowing current designated visitors more frequent private and personal visits will not significantly increase risk. These people are already visiting. We know who they are. They've washed their hands. They're wearing a mask. They've undergone health screening. They've had their temperature checked prior to each visit. We need to allow them to visit in the resident's room. This will also take tremendous pressure off the care home. I've operated care homes, and I can't imagine the pressure care home operators are under now, trying to manage the multiplicity of visits in common areas that they're now trying to manage. If we shift those visits to private rooms, a huge pressure valve will be released, and care homes will be able to focus on managing those visits that need to be managed in common areas and providing the essential care that they need to provide. It is true that for 25% of our residents who live in a shared room, more individualized arrangements will need to be made. However, the visiting experience for these residents has always been a bit different and more shared than for residents who have a private room. We also need to allow more than one immediate family member to visit. It must be acknowledged that this could increase risk, but we know how to manage that risk with our layers of detection and our layers of protection. Yes, the last 2 weeks, and specifically this last week, the case numbers from Fraser are extremely worrisome. However, we need to remember what family and residents have told us. We need to remember that some family members have been separated for almost 9 months, and we need to decide how long we continue these separations in the overall context of quality of life and other risks. We also need to consider whether regional approaches are warranted. We can absolutely begin work now on creating a provincial voice for residents of long-term care and assisted living and their family members. This has long been needed. Residents and family members are the voice we should listen to first and foremost about what life is like in long-term care and how we should improve it. We need to advance the no decision about me without me philosophy we are embedding in other areas of healthcare into long-term care. We know that shifting cultures takes a long time, but we need to start that journey now. This survey has told us that the capacity of family to care for one another is boundless. It has also told us that the wisdom and perspective that comes from living a long life is clarifying, and that when we know our time is limited, we focus on what matters most. And for most, if not all of us, that is spending time with the ones we love. This knowledge must guide us as we focus on the ultimate goal of managing this pandemic, which is quality of life. Thank you, and I will take questions now.
Thank you very much. As a reminder to everybody on the phone, please press *1 to enter the queue. You are limited to 1 question and 1 follow-up. Please also take your phones off mute. You will not be audible until your name is called. First question this morning is from Lisa Cordasco, CHLY.
Good morning, Ms. Mackenzie. Thank you for your report and your time on this. I'm wondering, what role does the provincial health officer play in making this happen, and what role does the Minister of Health play?
Well, under the current visit guidelines or restrictions that we have, we can certainly meet the needs of the current visiting family members who are looking for more time and more personal time with their loved ones. As I said, we can move those visits into the private rooms. And it was, I think, about 62% of the people who responded to this survey were designated visitors. That's what they want. They want more time, they want private time, and they want to be able to deliver those essential care services that they did before. That doesn't require a change in any orders. Allowing additional family members does require a change, and that would be a change from our provincial health officer. I know I've met with the provincial health officer, with the minister, with the medical health officers of each health authority, and with care home operators. And I know everybody is wrestling with this. And certainly, I think the recent numbers in Fraser Health have caused people to pause and to think about what kind of risk is circulating, certainly in the community of Fraser Health at the moment. But we are going to have to, at some point, look at increasing the number of people allowed to visit. As I say, we're coming into 9 months since these restrictions were imposed.
Lisa, do you have a follow-up?
Okay, yes, I do. 9 months. How long? How urgent? Can you express how urgent it is? Can you wait till after Christmas? Can you wait until the spring until we get a new vaccine?
I think the urgency is now. I think the residents have told us very clearly in this survey they are more concerned about being separated from their family members than they are about COVID. Risk is everywhere. Risk is everywhere in long-term care. We aren't protecting these people from dying. In a given year, about 7,500 to 8,000 people in long-term care will pass away. We need to look at what is the quality of life, and we need to look at what we know about managing this virus, how we know if we are screening you, if we are taking your temperature, making you wash your hands, making you wear a mask, limiting the numbers still. Nobody, well, I shouldn't say nobody, there's not a unanimous opinion about anything, but the majority, most people, do recognize there need to be some visit restrictions, and most people recognize and support that, actually. But we're talking about a very modest expansion of current visits. So do we start with the designated, you get an additional visitor, or do we start by saying you get an additional visitor if they are an immediate family member, or you get you can change your visitor every month to allow some of these dedicated adult children the ability to see their mom and dad sometime over the next year.
Thank you. Next question is from Richard Zisman, Global News.
Isobel, would there be any recommendations to do this based on regions? You keep mentioning Fraser Health, and that's where we see a bulk of the cases. Would you advise Dr. Henry or the province to think about this and open up care home visits in some areas of the province and not others?
I think we need to contemplate that. Certainly, we have taken a provincial approach to managing this pandemic, and I think we all have to agree that we have managed this pandemic relatively well. Even with these numbers we're seeing in the last few weeks, when we look across the rest of the country, we're still managing it relatively well. So you don't want to abandon the strategy that has made you achieve some desirable outcomes. But we did see, for example, with surgical cancellations and the creation of bed capacity in acute care, that there was an acknowledgement that we will do that on a regional, a more regional basis going forward. We already have arguably a site-specific response in that we do lock down completely a care home where there is an outbreak. So is it reasonable to say that there are some communities where there is a demonstrable difference in virus that is circulating in the community, and we may need to have a different approach there than in other areas? I do think we need to look at that, especially if we're looking at 3, 4, 5, or 6 months more. We don't know where our numbers are going to head.
Do you have a follow-up, Richard?
Isobel, I'm just wondering how you know that these visits won't lead to spread of the virus. Because obviously that is the biggest fear here, is that someone brings the virus into a long-term care facility and it leads to rapid spread that would likely lead to death. You know, you speak to saying that people are screened and they're tested and they wear their masks, but how do we not know that they're asymptomatic and this could lead to more spread inside a home?
The fact is, if we look at the people who are currently visiting and expanding their visits, that risk is already there. We're not increasing that risk. They are already coming in. We are just having them come in more frequently, and there's an argument that we're actually reducing risk by having the visits in the private rooms. When we look at having additional people come in, which is a different issue that's been identified by family members, then you are mathematically increasing the risk. It is absolutely possible that they will bring the virus in. But I think, Richard, that the context here is to listen to the people that live there who are saying that's not the risk that they fear the most. We have risk everywhere out there. We have children going to school, teachers going to work. We have people getting on buses. We have drivers driving buses. We have people in grocery stores, people shopping in grocery stores. We set out saying we had to learn how to live with this virus and how to manage it. And we absolutely needed that time in the beginning to determine how we were going to do that, to get our PPE in place, to get our staffing in place, to get a number of pieces in place. So what does it look like when we live with it? Because when do we start to say to the person living in long-term care, at what point they're never going to see their daughter again? That daughter may have come to visit them every other day. Let's say, this is not uncommon. You've got the spouse is the one that's the designated visitor. They come every day. Their daughter used to pop in and see dad 3-4 times a week. She hasn't seen him now for almost 9 months. Is she never going to get to see him again? Because he's going to die. Not from COVID, but from, and that's the challenge here. It's part of this bigger conversation and recognizing that what are we keeping them safe for if it's not to spend the precious time they have left with the ones they've loved. These letters, thousands that came with this survey, time and time and time again. They would rather have COVID than never see their son, their daughter again.
Next question is from Moira Witten, the Tyee.
Hi, Ms. Mackenzie. Thank you so much for this report and your work on this issue. I'm wondering, you mentioned some figures around the number of people in a given year who pass away in long-term care or assisted living and how many we've seen since the pandemic, unrelated to COVID. I'm wondering if you have any insight into whether these numbers indicate excess deaths due to worsened illness or conditions that were exacerbated due to changes in care or COVID prevention measures in facilities.
No, we are not seeing yet in the data, and I say yet because there's what we call the time lag. It takes time to see a pattern emerge. We are monitoring this. We aren't seeing excess deaths once we factor in the COVID deaths. That's not to say that a year from now, when we look back, we may or may not see that. What we are seeing, though, is the dramatic increase in the use of antipsychotics, and we're also seeing in our Q1, our first quarter of our inter-eye assessments, we are seeing some trend lines. We'll know more when we see the Q2, the second quarter assessments, which we'll get about the end of November, beginning of December. These patterns around worsening of mood and symptoms of depression, unexplained weight loss and delirium. And there is certainly evidence to suggest that there's a negative impact on the health and well-being. But there's no evidence at this point to suggest that they're literally those are the reasons they're dying. And part of it is it's going to be subtle and difficult to measure. You have to remember that in long-term care, many people are in the last year of their life. So when you look at excess death data over a year, there's some subtleties you won't pick up when you look at it for long-term care.
Do you have a follow-up, Moira?
I do, thank you. You actually touched on it earlier in your answer. But in terms of the use of antipsychotic drugs and the troubling rise this report shows, how are you, I guess I'm curious how you might ask the government or the provincial health officer to move forward with increasing transparency and, I guess, rights of families to prevent that sort of intervention with their loved ones, just because I'm quite surprised at that jump when families aren't necessarily there to, act as a more social means of calming someone's mood.
Well, I think that's sort of the basis of the third recommendation, which is to create a provincial association of family and resident councils. We've got to find a way to get the voice, a collective voice, of residents and family at the table. Over this pandemic, there has been a lot of consultation and a lot of focus on long-term care. The government cannot be faulted for that. This is not because they don't care. But at the table are the industry associations that represent the care home operators and the health authorities that operate the care homes, and you have the unions and the safety associations for the employees. There's nobody there for the residents and the family members because there's no collective voice out there. There's no association that the government can go to and say, tell us your perspective on this. And we need that. We needed that way before this. And that's a whole other story for another day. But now we really need to move forward with that. And this demonstrates the frustration that these families feel and that these residents feel over not being heard is almost as difficult and traumatic as the separation from their family members. They feel absolutely powerless because they feel they're not being listened to. I don't think that's true, but I think that they feel that way because there's no effective way to harness their voice.
Next question is from Mike Hager, Globe and Mail.
Hi, Isobel. Thanks again for this survey and the findings. Going back to the medication of residents, do you have a baseline prescription rate? I know that perhaps a decade ago, about a half of residents in long-term care were prescribed antidepressants. Can you talk about those other psychotropic prescriptions and whether those have also seen a rise since the pandemic touched down in the sector in March?
Yes, we have. We've seen an increase in antidepressants as well. It's not as dramatic. It's a 3% increase. We haven't identified antidepressants as the use, I should say, of antidepressants as a quality indicator to the degree we have antipsychotics. I know that if we look back 10 years ago, we made a concerted effort to focus on reducing the use of antipsychotics in long-term care for a whole host of reasons. They are very, very powerful drugs. And we made a lot of success here in BC. We aren't as successful, frankly, as some other provinces like Ontario and Quebec, but we did decrease our use of antipsychotics, and we were very pleased to see that. These last 7 months have basically wiped out all those gains of the last 4 years of efforts to reduce antipsychotic use in long-term care. So we are really, I am really concerned about that one. And then I am very much waiting to hear what the Q2 clinical assessments are when they come in. We've heard residents, they're not clinical assessments, but residents have said, over half of them have identified that their loved one is worse now than they were before. Some of that is a natural process. In a given, what we would call a quarter, in a given 3-month period, we would see about 25% of residents experience some of these worsenings. But residents are reporting it's half, so that's double.
Do you have a follow-up, Mike?
Yes, apologize, double-barreled, but is the nature of the infrastructure here in BC contributing to the rise in antipsychotics? You said that Ontario does it better. Are they helped by more residents being bunked with other residents within a room? So shared accommodation, is that helping people kind of weather that storm further east? And, people living in single suites, do you think that's contributing to the rise in antipsychotic use, that extra isolation? And as well, the family councils, was that not legislated at facilities that receive government funding? Would it not be an easier fix to, if it's not legislated, to mandate that every long-term care facility have a family council that has a seat at the decision-making table?
So the first question, Mike, around the antipsychotics, my comment about our experience relative to Alberta and Ontario is pre-COVID. I don't know what the antipsychotic use is in Ontario at the moment. This is from our prescribing data, and I don't have access to Ontario's prescribing data. So I think that actually overall in long-term care, we've managed things better than Ontario has. And I think that that's not a subjective opinion. I think if you look at some objective indicators around how many care homes experienced outbreaks, how many spread, resident infections, et cetera, I think you will find that we've done better. There are many reasons for that. There's not a single reason, there's many reasons, but we have done better. I think in terms of the family councils are not regulated or legislated currently in BC. They are referenced, and care homes are encouraged, for want of a better term, to have them, and many care homes do have family councils. There is a move that we should be regulating or embedding in regulation or legislation that there must be, and that the other issue is that the current way we have resident and family councils is the only relationship is with the management of that care home. So if I'm on the family council in my dad's care home, I'm really just talking to the care home operator about there's no mechanism that the health authority can know what's happening, or that the province can. We need to knit that together and bring a collective voice and experience up to the health authority level and then the provincial level with our resident and family councils. And I think as we do that, they'll be strengthened across the board, because they'll have the type of voice and leadership that they need to be at the decision-making table.
Next question is from Eva Eugen, CBC.
Hi there. I was just wondering, you mentioned you recommend more social visitors, and I've spoken to many family members who basically won't be satisfied until visits kind of are back to their levels during normal times. So I'm wondering here, is the recommendation that that be the case just with the extra screening and mask wearing and that kind of thing, or are we still restricting it to like a select group of people within the family? Like, how is that what are you recommending there?
Well, I think there's wide support for some visit restriction. So we aren't going to return to unrestricted visits with birthday parties with all the grandchildren and the cousins. That will not happen until the pandemic is over. I think we all recognize that. What we're talking about here, again, there's basically two groups of people. There's the people who are already visiting as the designated visitor. They need to have more time with their loved one, and we can do that without increasing risk. The other group are the people who aren't able to visit right now because they're not the designated visitor. And so we need to approach this in a way, from my perspective, and it's what is in my recommendation, that rather than give a blanket number that says you can have one additional visitor or two additional visitors, that it is approached from the perspective of who are the immediate family members and what is the impact of these visit restrictions. And do you have a designated social visitor who comes once a week, and then you might be able to have somebody a daughter who in the past only visited her mom twice a year when she flew out here from Toronto, may still be able to do that. But in the week that she comes, the other social visitor can't come. I think there is a way that it can be managed that will satisfy most. It won't satisfy all. There's no question in the survey that had a unanimous answer. So clearly, what we need to do is look for, okay, what do we really need to do here? Number one, these spouses need more time than 30 minutes once a week outside or in a common room. We need to fix that, and I think we can fix that now. And we're not increasing the risk. Then we need to let more family members in. That one has become more complicated in the last week because of what's been happening in Fraser Health. So I think we need to ask ourselves, okay, if we took Fraser Health out of the equation, what would we be doing? And we need to think about that. I know that has not been how we've approached things to date, but we're now 9 months into these visit restrictions. And then we need to, moving forward, find a way that residents and family members can feel their voices heard. We need to give them a way to do that.
Do you have a follow-up, Eva?
Yeah, you've acknowledged that regardless of all the precautions taken, this is an increased risk, but that's not necessarily the a priority for seniors who are nearing the end of their life and who don't want to be alone. But what about how that increased risk is going to put healthcare workers more at risk by exposing them to more people and more visits? Like, how do you balance that?
Well, again, I think we need to remember our layers of detection and layers of protection. So how are they more exposed than if they're going to the shopping, the grocery store, or getting on a bus, or getting in a car with other people, or their kids are coming and going from school? The shared risk is everywhere. And what we're doing is taking personal responsibility around shared risk by making certain that we wash our hands all the time, by wearing a mask, by not gathering with groups of people in social environments. And we're able to do that. There's no record to date of any outbreak in long-term care as being transmitted from a visitor. So, we need to look objectively at that. As the care home staff are definitely understaffed. But some of the people who responded to this survey were care home staff, and they also desperately want, some of them desperately want their residents to be able to, if not see more people, spend more time. We need to recognize that not only are these family members essential care partners to their loved one, they're also essential care partners to the system, to a much overburdened long-term care system. When we look at the number of people who were visiting several times a week or daily, and they were helping with personal care, they were feeding, they were mobilizing, they were making sure the hearing aids were in and the hair got combed. Okay, all of those tasks that were done by the family member, who's been doing them? The staff have. They have been absolutely overburdened. And I think the reality of what we're seeing in some of these absolutely objective clinical indicators, like antipsychotic use and our clinical inter-eye assessments, is validating that. So there's a total picture here that we've got to look at, and we've got to listen to these people. These aren't my recommendation. This 13,000 people have said we need more time with our loved one, and it's 9 months.
Arnett, Times columnist.
Hi, thank you very much for this. Given your last answer, how do you make all of those accommodations safe for families, and then possibly make regional recommendations, and at the same time have a recommendation that gets away from the uneven application that we've seen of the rules from home to home?
Well, I think if, first and foremost, I think if visits are allowed in the residence room, and it's by exception that they aren't, a number of the issues we heard about will start to fall off the table. The minute you move those visits to the private rooms, you are going to have, as a care home operator, capacity to manage many more visits during the day. Because right now, you're having to shuffle people out of their 30-minute time slot in the cafeteria because you've got to put another family member in there, and you've got to get the resident there, and then you've got to get them back to their room. And it's extremely, extremely time-consuming. That doesn't solve all of the problems, because you've got the 25% who don't have a private room, and those are going to be trickier to manage. We know that if we increase the amount of time that people can spend with each other, not all, but many of the issues that people are speaking of in this survey are addressed. For example, the widow whose story I highlighted at the beginning, if she could have been with her husband in his room, many of her issues were resolved, and she would have had that meaningful time. Her husband may still have passed away, but she would have been able to be with him when that happened and have had meaningful time with him before it happened. Looking at increasing our numbers from 1 to whether it's 2 or whether it's by exception 2 or whatever the next step is, and I think it will be what we call iterative. We will have to do this, I think, in a responsible way. We've got to, I think, recognize that if over the longer term we are going to see regional eruptions of cases that are going to inform our province-wide policy, we're never going to get to the point where we're going to allow additional people to visit. Because, if not now, then when would be the question. What does it have to look like before we will allow an additional person in? And I think that we might also be giving we should give consideration to more specific direction to some care home operators. I think that there's been, and that also came out clearly, a wide difference in application and interpretation of guidelines, and that was absolutely clear in the essential visits, that it was very differently interpreted by different care homes. And family members are frustrated by that as well. That's what's leading to some of these visits being outdoors or with plexiglass versus being in the resident's room. I don't know if that answered your question.
A follow-up, Cindy?
I think I'll clarify the question. So just 2 clarifications then. If the order or the recommendation is expanded on visits, should it be made clear that it applies to all care homes in the province, private, public, or otherwise? And as another clarification, I would ask you to explain the relationship between the rise in antipsychotics from your experience and the visitor restrictions, please.
Okay. So, yes, thank you, Cindy. To be absolutely clear, yes, I think that we need to communicate with absolute clarity to care homes that visits need to happen in the resident's private room. The issues around how visits are managed for residents that don't have private rooms is always going to be difficult to have absolute clarity on, because the circumstances will be very different depending on whether there's 2 people in the room, 4 people in the room, what are the options for common areas, and what are the conditions of the residents. So I think that group of people are always, it's always going to be more difficult to be clear about. And I think we also need to give guidelines around frequency to deliver essential care services. The care homes are still going to have to manage the visits, and the limits don't have to be how many people can I fit in the visiting room, because if you go to the private rooms, your capacity's increased significantly. Almost half of our care homes have got only private rooms. The issue, though, is you need to screen the person. So there's still this, how many people a day, I absolutely believe we have to do that. And even that we're not doing completely uniformly either, but we're doing a pretty good job of it. You've got to ask them the health screening questions. You need to make sure they wash their hands. You need to take their temperature, and you need to make sure they're wearing a mask. So it is going to take 5-7 minutes per person to be able to do that. So we can only have so many visitors come in during a period of time. So there's still going to be, they've got to be scheduled. But I think we could also look at some type of formula that would determine how many visitors a day could come into a care home. And we would base that on the numbers of rooms, the numbers of private rooms, and make it clear that that's the expectation, and make it clear to family members who they turn to if that expectation is not met, and how it's remedied.
Rob Monroe, Info News.
Thank you for this, Isabel. To my mind, one of the key recommendation is the Association of the Family Councils. And it seems to me that some of these other things you're talking about could take some time. And is there any way you can start? I know it takes a budget to get all this together the way I think you would like, but is there some way to start pulling these different groups together, because they're going to want to advocate for your report to be implemented, which it may not. So can that process get started in some way?
I believe it can. This report was put together in, even for my office, record time. I have, as I say, I've briefed the minister and the deputy and the provincial health officer on this, and it is my hope that they will take up that action and that recommendation. That doesn't carry any risk to it, and get that going as soon as we possibly can.
Do you have a follow-up, Rob?
Well, just on that, is there anything, I know there's a number of Facebook groups out there and advocates, is there something your office could do while you're waiting for government to try to give those people that voice, or try to focus them in some way? I know there's different people there trying to organize what groups are there, but can you assist in some way for that?
Okay, I get thank you. Yes, that is a good point, and yes, that is something my office can do. I will hopefully be meeting for follow-up with the ministry next week, and we'll see where they're at, and certainly it is something I can move forward with sooner rather than later, if their appetite isn't there to do this. And I realized there was one question I did not actually answer. I think it was Cindy Harnett's, around the antipsychotic and the visit restrictions. And I think the question was, how can we draw the parallels between the two? And I think the short answer is it's always this isolating the variables. What is different now from before that might be causing this? So if we look at the time series chart in the report, it shows that I think it's a 3-year time increment with the same moment in time data point across the continuum. And so you can see that it sort of bounces up and down a bit. When you look at the line when the pandemic started, you then see a very clear upward slope, a little dip, and then the upward slope again. So what are the variables that are different? Well, the visit restrictions. Is it the visit restrictions in and of themselves? That is difficult to determine. The visit restrictions may also be resulting in less socialization and mobilization even within care staff, because, as I spoke about earlier, who's doing all these personal care, grooming, feeding, mobilizing that family members did before. So that could be part of what we're seeing reflected there as well. But you sort of you look at a number of patterns are emerging in a number of different ways we measure things, and they are definitely pointing in the direction that we are seeing some significant deleterious health impacts on the residents of long-term care and through this pandemic. And arguably it is from the isolation that they've been experiencing, because that's what's different for them.
We have time for one more question today, and that is from Michelle Bernaro, CTV Vancouver.
Hi there. Thanks for taking my question. You've actually answered it just a short time ago, but I am just looking for clarification then. We were looking at this, and again, it goes back to this 7% rate increase in the use of antipsychotics. So just to clarify, this is what families are reporting. Is that accurate?
No, this is actually our prescribing data. So one of the ways that we look at the use of antipsychotic is we use what we call our inter-eye assessments, but they are only done every quarterly. We only have Q1 data. This is telling us how many unique people in long-term care are being prescribed antipsychotics, and that rate has increased. So this is objective, not observational. Data out of PharmaNet, out of, I think, the Plan B. I should qualify that this represents 2/3 of care homes. Community, CCALA, Community Care Assisted Living Act sites. Those that are under the Hospital Act site have a different PharmaNet or pharmaceutical regime, drug plan, I think is the way we say it, and we can't tease that data out. But this is, as I say, a little over 2/3 of our sites. So it's a pronounced pattern.
Do you have a follow-up, Michelle?
Yes, again, just a clarification. So then when you're talking about this worsening of condition in about 25% of residents, is that based based on the criteria that is being observed in the homes, and then families are seeing in addition to that, or is that just what you would generally see?
That's what you would generally see. So what we know is that about 50% of families reported that when they saw their loved one again after the first phase, so after about 3 or 4 months, over half of them said, yes, their physical condition is worse, their cognitive condition is worse, and their emotional well-being is worse. In the normal course of events, if we look in previous years, in a quarter, 3-month period of time, we would generally find that about 25% of our residents would present with demonstrably or markedly worse conditions around physical function, cognitive function, and emotional well-being. So it's that comparison. We will know more on this when we get the Q2 data out of our clinical assessments. We won't have that until the end of November, beginning of September. And I think we really will know what the story is when we get our Q3 when we get our Q3 data as well. But I hope that answered the question.
That's all the time we have for the press conference today.
Okay.
Thank you for joining us.
Okay, thank you very much.